Okay, next, we would like to hear from Dr. Chun-Kai CHEN, a medical doctor specialized in OBGYN, who has been a research fellow in human genetics and embryology at the University College London, and assistant professor at the Chang'an Memorial Hospital, one of the largest and most comprehensive healthcare providers in Taiwan. And currently, he's the chief director of the Hope Fertility MPGT Center in Taiwan, and came here today to share with us a few insights on the future of the non-invasive PGT-A. He's also a very good friend of mine that we share a lot about the science and latest updates of the science. Let's welcome Dr. Chen. Please, Dr. Chen.
Hello. Thanks Igenomix provides this webinar meeting to let us share experience with you all, especially in this pandemic period. Today, my talk will be whether it is the time for ni-PGT-A to clinical application. I'm Dr. Chen, previously worked in Chang'an Memorial Hospital, Linkou, Taiwan. Now I have been running an IVF center for 7 years. We have nothing to disclose. Okay, when we look back the developmental history of embryo aneuploidy testing, there were 3 stages. The first one was stage 3 biopsy and fresh embryo transfer. The diagnostic technique was 3-color fish, 5-color fish, or multicolor fish. However, the number of chromosomes to be detected were limited, and the information was not much. The second stage was stage 5 biopsy and freezing embryo for future sowing and replacing. Diagnostic techniques were array-CGH, single nucleotide polymorphism, or qPCR, which can have detailed information about 23 pairs of chromosomes. The third stage was using NGS for diagnostic method. Mosaicism status can be detected. The non-invasive method, so-called ni-PGT-A with span culture medium, was getting noticed in recent years. The PGT-A has come to the 3rd generation. Why do the scientists want to find other ways for embryo aneuploidy testing? There are still continuing debates about the benefits and harms of PGT-A. The benefits are selecting euploidy embryo, reducing miscarriage rates, and therefore facilitating single embryo transfer, decreasing multiple pregnancy rate, and increasing implantation rates, increasing live birth rate, therefore reducing time to pregnancy. However, it may need more cycles to collect enough blood sources to do the test. It does not improve cumulative pregnancy rates, but the mosaicism at this stage would confound the results. Also, PGT-A does not create euploidy embryos. Moreover, the biopsy procedure might harm the embryo and lower implantation potential. Recently, San Diego Munan organized a multi-center trial called STAR trial. They evaluate the benefits of PGT-A with NGS for embryo selection to transfer. Unfortunately, the result did not show benefits and improvements on overall pregnancy outcomes. They analyzed the possible reasons. The first, the Mosaic embryos were mostly not replaced. The percentage was about 8%. The second, biopsy procedure might have some damage on embryos to hinder growth. The percentage was about 17%. Last year, there was a multi-center study about the result of Mosaic embryo transfer. According to the result, the PGT-A report provided as selection priority criteria rather than just yes or no. The highest successful rate is the segmental mosaicism. The lowest is the high-level complex mosaicism. Even more, Dr. Norbert Gleicher reported that he replaced embryos with abnormal chromosome reports and get some successful deliveries. Furthermore, if we can get the DNA sample in non-invasive way, such as collecting sperm culture medium, we might improve the successful rate and see the benefits of aneuploidy testing. So, first of all, we should know what kind of DNA source inside of sperm culture medium. Inner cell mass, travated them by cell lysis, apoptosis, or shedding of cell debris. There were also potential sources of contamination from cumulus cell, sperm, polybody that may persist to blastocyst stage. Even more, culture medium may be contaminated following manufacture or during culture period. Professor Chen and his team announced their study result in 2016. They collected day 3 to day 5 culture medium and did chromosome analysis. They used mail-back method for WGA and NGS. The results were compared with those of whole embryos for validation. They further applied the method to 9 couples. 5 of them achieved live births. The results of 42 sperm culture medium samples were compared with those of whole embryos. False positive rate was 16%. False negative rate was 11.8%. Sensitivity was 88.2%. Specificity was 84%. Positive predictive value was 78.9%. Negative predictive value was 91.3%. So they concluded false negative mainly from maternal contamination. False positive mainly from mosaicism. Negative predictive value higher than positive predictive value, suggesting ni-PGT-A more effective in selecting normal embryo to transfer. Remove of cumulus cells is crucial to decrease false negative rates. ICSI is highly recommended to avoid supernumerary sperm attached to zona pellucida. ni-PGT-A is considered as a screening assay for chromosomal level abnormalities instead of a diagnostic assay for segmental aneuploidy. Later, the team in 2019 cooperated with Professor Catherine Rokowski, published another study. 52 donated blastocysts with TE biopsy results were thawed and cultured for 24 hours. They did chromosomal analysis of sperm culture medium and the whole embryos. The data were compared with those of TE biopsy. They concluded from the study. Remove of all cumulus cells, false negative rate can reach 0%. Positive predictive value and specificity for ni-PGT-A are higher than those for TE biopsy. The concordance rate for ni-PGT-A is higher also. ni-PGT-A is less prone to error due to mosaicism. So ni-PGT-A for sperm culture medium may be more reliable than TE biopsy. From the literature review, we know that the major concern of ni-PGT were the low DNA concentration, contamination, and the origin of DNA. In 2019, Perkin-Elmer also announced their WGA product for ni-PGT-A. So in 2019, we start the first round of tests, washing on day 3, assisted hatching on day 4, collecting sperm culture medium on day 5, and do biopsy. Unfortunately, the concordance rate of sex was poor. We saw it should be the problem of maternal cell contamination. In 2020, we tried another round of tests, washing on day 4, and collecting sperm culture medium on day 5 or day 6 when biopsy was done. The concordance rate of sex was poor also. We saw still the contamination was the major problem. So when we felt frustrated, we read the paper by Igenomix in 2018. They proved embryonic DNA did persist in sperm culture medium and not necessarily apoptotic in origin. Furthermore, they demonstrated the discordance was largely due to maternal cell contamination. Here, they collected sperm culture medium from day 3 to day 5. Later, Igenomix set up a new protocol to collect sperm culture medium, which was published in 2019. The protocol said standard culture till day 4, then serial washes on day 4 to remove cumulative cell as clear as possible. Then change to a new drop culture till collection on day 5 or 6. For cell-free DNA chromosome analysis, they use modified reproseq protocol and iron-tolerant platform. Sperm culture medium day 4 to day 6 had a better informative rate and better concordance rate than sperm culture medium day 4 to day 5. The concordance rate of sperm culture medium day 4 to day 6 was 84%. 2.5% were false negative, that is euploidy medium and euploidy biopsy. 8.5% were false positive, that is aneuploidy medium euploidy biopsy. Also, they found that transferring embryos with euploidy sperm culture medium had a better clinical outcome than embryos with aneuploidy sperm culture medium. They expanded the method to multi-center and got a rather consistent data among different centers. They also tried to set a scoring system for embryo selection priority by ni-PGT-A report. We start to follow the protocol of Igenomix for collecting sperm culture medium, that is washing on day 4 and collecting sperm culture medium on day 6 or 7 when biopsy was done. Totally 27 pair samples. One sperm culture medium data was non-informative. One T biopsy report was non-informative. 2 Brussels cysts were found hatching, and 1 Brussels cyst was found hatched on day 6. Then the lab had to handle the hatched Brussels cyst, including biopsy and vitrification. The concordance rate was 84%. 4% was false negative. 12% was false positive. The informative rate was 96.3%. If we calculate the statistics, false positive rate is 21.4%. False negative rate is 9.1%. Positive predictive value is 76.9%. Negative predictive value is 91.6%. Sensitivity 90.9%. Specificity 78.6%. There were 5 embryos transferred back in 4 patients who got pregnant. The first 1 patient is now at 12 gestational weeks. The embryo transferred back had ni-PGT-A report of segmental aneuploidy. The other patient is now pregnant at 7 weeks. 2 sacs, 1 is empty, the other has fetal pole about 1 centimeter. The last patient had only 1 euploidy embryo by TE biopsy. Although ni-PGT-A data was aneuploidy, she decided to have transferring, but without success. With the similar method of washing and collecting medium, we tried to wash on day 4 and collect sperm culture medium on day 5 when biopsy was done. 2 of the 3 samples had no DNA detected by PGT-A. The third sample had non-informative data. In 24-hour culture medium was not suitable for this platform. We tried to change the time of washing to day 3 and collect sperm culture medium on day 5 when biopsy was done. All the 4 sperm culture medium samples could get informative data. However, the concordance rate was poor. Moreover, 1 was not concordant about sex. We saw the problem of maternal cell contamination for day 3 to day 5 sperm culture medium persisted more than day 4 to day 6 sperm culture medium. Coaching course on PGT last November, Cooper Genomics presented their experience. Concordance is highest on day 6 or 7. Overall, their concordance around 76%. False negative rate and false positive rate both 28%. Identification of maternal cell contamination can improve concordance to over 80%. From their data analysis, they warned that up to half of concordant euploidy female samples may have maternal cell contamination. Maternal cell contamination may contribute to discordance of male euploidy samples. So they warn that this might be a soaring question for PGT-A. So come back to our data. These sperm culture medium samples, their TE biopsy reports were all male pattern. If they have maternal cell contamination in sperm culture medium, we could be able to notice. However, if their TE biopsy reports were female pattern, we probably could not tell whether there were maternal cell contamination in the sperm culture medium, also to what extent the contamination will be. Summary of our experience. Different WGA kits with confident amplification efficiency provides choices for PGT lab. In our series, the informative rate of sperm culture medium was 96.3%. Careful removal of cumulus cells on day 4 could decrease maternal cell contamination a lot. Sperm culture medium of day 4 to day 6 is sufficient to get ni-PGT-A data with concordance rate of 84% to TE biopsy. The resultant embryos could get good clinical pregnancy. And this possible promising beginning of ni-PGT-A. So in the future, we should study inherent damage of a string washing on day 4, how to make enough washing but not too much. We should study the effect of extended culture till day 6 for some fast-growing basal cysts. Although we did not see any harm in our series, we still need more data to prove. We need to refine the schedule of collecting sperm culture medium to fit routine clinical setting. We need to find ways to further decrease the maternal cell contamination if possible. We need to find easy method to detect maternal cell contamination if happens. At present, if we want to detect maternal cell contamination, we need to do single nucleotide polymorphism sequencing using associated triads of DNA from sperm culture medium, trifecta biopsy, and follicular fluid sample. We have to find other easy way and economic way to do. And also, we should study the influence of IVF procedures like assisted hatching, freezing, sewing on cell-free DNA in culture medium. So that's the last slide. Thank you for your listening.
Okay, thank you very much, Dr. Chen. It was a very interesting presentation. So we have a few questions here from our audience. I would like to ask you. I think we have about 5 minutes, so I can we can pick some of the interesting questions for you. The first question is, do you think the embryo is affected by the extra culture time and the extra wash at day 4?
Yeah, that's a concern, but actually in our series, so far we didn't see any harm of the washing or extended culture to day 6, but we need more data to prove.
Thank you. And then what if embryos hatch? What do you do? How do you handle that situation?
Yeah, just as in my talk, in our series, there were 2 hatching on day 6, but it is okay because anyway we need to let the embryo hatching before doing biopsy. But for hatched, that is go out of the zona, I think the embryologist has to handle them very softly. Yeah, and there is one hatch, and the biopsy and vitrification is okay. Yeah.
Okay, and then I know that you have tried a few different method protocols than what Igenomix provided. For example, we are suggesting to wash on day 4 and then culture to day 6. And I remember you have tried, to wash on day 3 and culture till day 5, or wash on day 4 and culture only 1 till day 5. And then what did you see the result look like?
Yeah, as in my talk, we try to find ways to fit the clinical setting. In the usual clinical setting, usually we change median on day 3 and then do biopsy on day 5 once it become good processes. But as you know, just in my talk, day 4 to day 5, the incubation, the culture time is not enough to get enough DNA. And for day 3 to day 5, the DNA amount seems okay, but there is still the problem of maternal cell contamination. Maybe the cumulus cell still cannot remove enough, so that some contamination still persists. So we go back to day 4 to day 6 span culture medium.
Okay, thank you. And we also have a question or a request that a doctor from Ho Chi Minh City in Vietnam that would like to learn from your experience. We'll try to connect you to this doctor after this seminar. Okay, and also we have another 1 minute, so we will ask you a last question. So being the pioneer of non-invasive PGT-A provider in Taiwan, I think in Asia too, what was the key reason that made you consider offering this new technology? And how would you suggest other doctors to, what kind of strategy would you suggest other doctors to take?
Yeah, I think just in my experience, in the first step, we have to follow the protocol step by step. Once the protocol is settled down, then maybe you can try to use that protocol to fit your clinical setting. Yeah, but before you change the protocol provided by the PGT lab, you have to follow them just by their step, so you can get the good data at the first step. Then you can be confident about your data and show and explain to your patient, then go next step.
Okay, thank you very much, Dr. Chen. Thank you very much for your presentation and answering all the questions very detailed. Thank you again. Thank you.